This week on the BackTable podcast.
You should probably get comfortable doing some of these sort of flexion angiograms. We don't routinely do that unless we're treating popliteal artery aneurysms. It's funny, every time you treat a popliteal artery aneurysm, you do this to see where to land your grafts and make sure you don't have any kinking. But we don't do it for an atherosclerotic case. So it's not a bad idea until you get comfortable with these things and understand your patient and where that compression is occurring. After you put that stent, go ahead, do that flexion angiogram, and you might learn something really valuable in terms of, whether you have enough metal, you need more metal, you need less metal, and how you can optimize your results.
Hello, everyone, and welcome to BackTable, your source for all things endovascular and more. You can find all previous episodes of our podcast on any platform like Spotify or even our website, backtable.com. You can also follow us on Twitter, Instagram, or LinkedIn, and keep up with the latest updates and give us feedback through comments. This episode is sponsored by Veryan Medical and the BioMimics 3D Vascular Stent System. The BioMimics 3D stent is intended for the treatment of peripheral arterial disease in the femoral-popliteal arteries. The BioMimics 3D stent has a unique 3D helical geometry which enables the stent to shorten with the vessel, improving its biomechanical compatibility and reducing the risk of stent fracture and trauma to the vessel. Veryan has amassed a significant body of clinical evidence that supports the hypothesis that BioMimics 3D's helical design impacts outcomes and demonstrates superior, long-lasting clinical results in this challenging segment. Learn more at veryanmedical.com. I'm Sabeen as your host today, and I'd like to welcome Dr. John Rundback, an interventional radiologist from American Endovascular and Amputation Prevention in Teaneck, New Jersey. Welcome, John.
Thank you, Sabeen. A pleasure to be here.
Absolutely. We're excited to have you on the show. Today we're going to talk about a real tough spot to treat, that dreaded distal femoropopliteal segment. It's a challenge. It's a challenge for many reasons, which we're going to go into. But before that, let's have our listeners get to know you a little bit better. How'd you end up in New Jersey? And tell us a little bit more about American Endovascular.
Sure. Well, first of all, a shout out to you, your new dad. So congratulations on that. So
thank you. Thank you.
Listeners should know about that. So you've taken time out of your new family to do this, which is amazing.
We're getting discharged today, actually. So I came back to record and coming back here.
Okay. Amazing. Amazing. So I'm an interventional radiologist for 30 years now. Hard to believe. Time goes quickly. And I've always been very active in peripheral arterial disease. I tell the story that when I started doing this, there were very few people other than IRs who were doing PAD. And, we've sort of developed a lot of skill set. I've seen a lot of things change over the years, but, certainly it's exciting time to be practicing now. In American Endovascular and Amputation Prevention, we focus really on the critical limb ischemia population. It's probably 70% of what we treat. But inherent to that and relevant to today's talk, there's a lot of femoropopliteal disease. Our patients, and probably much like yours, tend to be the most complex patients. Patients with chronic kidney disease, diabetes, heavy smoking, and other patterns which are associated with calcification, long segment occlusions, and the like. So that's what we're treating on an everyday basis. It's a real challenge, but it's fun. And like you, we've been getting some pretty remarkable results, which has helped with some of these new technologies.
Yeah. The new technologies have helped us a ton. We'll agree that just angioplasty alone now, in that segment is probably not durable.
Yeah. I think you're going to get to this, but, with the advent of the drug-coated balloons and drug delivery technology, there was this whole idea of leave nothing behind.
Yep.
And I'm sure we have a chance to talk about that. I'm not sure I was ever completely on board with that, nor did it ever completely make sense. And of course, if you even look at the drug-coated balloon data in the long lesions, 40% or more of those patients need scaffolds anyway. So.
Absolutely. So what makes, the pathophys of fem-pop, that whole distal fem-pop area, what makes this area so tough? Why can't I just do a POBA there and call it a day and do that?
Yeah. Well, you're probably familiar with the biomechanics of the femoral-popliteal artery across the adductor canal. It's really unique. And we've all seen those really nice pictures with patients with their knees bent. And, you can get a sense of the torsional and the compressive and the elongation, other forces. It's a very dynamic part of the artery, but they've actually done some studies and you get compressive forces right across the adductor canal and just below that, up to 15 or 20% compression of the artery, foreshortening of the artery. And if you think about it, this has always been my feeling, traditional slotted nitinol tubes are rigid stents. They can't foreshorten. They can't, rotate in response to those physiologic stresses. And therefore, they're inherently provocative. They can never endothelialize well. And they're always leading to this, activation of the restenotic cascade.
Okay. Without a stent, when we're doing our angio initially, almost at Hunter's canal, there's some sort of, it could be a mild stenosis or a really severe stenosis. I mean, is the artery just subjected to a ton of injury during someone's life, susceptible to PAD? Like, why do you always see it? I've always wondered, like, what's going on right there?
Yeah. Especially since if you look at patients with atherosclerosis, often there's no rhyme or reason why they have disease, where they have it. But that's a relatively constant. That's the location where you get disease. And for SFA CTOs, that's the point most of the time of reconstitution, right? Indicating that's where the culprit lesion is. I think one is crossing the adductor magnus and adductor canal, and that's some external forces. So there's probably some factors like that, some external constraint on the vessel. But more importantly, like I said, that's the most physiologic or biomechanically dynamic location in the SFA. And therefore, it's subject to these twists and turns and compression that you just don't see elsewhere in the SFA. As you get disease, that's where you're going to get plaque rupture. And that's where you get unstable atherosclerosis. That's where you're going to get occlusions. Yeah.
What's funny is when I started, delving in PAD, and I used to think that the main flexion, you would just think kind of logically that the main flexion is right behind the knee joint, like where you see the femur and the tibia, like you think that's the flexion point, but it's not really. It's a whole long segment that's going through twisting, movement, compression, like you mentioned, right? Where and other than Hunter's canal, what parts of the distal femoropopliteal segment are affected? Is it all of it, or the distal end, or Yeah,
it's pretty much starting at or just above the arterial canal and extends down into that P1 segment. And interestingly, and this was new to me in a sense, who's looked at this more recently, the predominant force is a compressive force.
Dominant is compression. Okay.
Yeah.
Okay.
Yeah,
so it's not bending, it's not flexing, it's compression.
All right. And so it's really, that artery is really foreshortening. And to do that, if you look at it, the artery kind of spins, it rotates, it kind of, gets this wavy configuration to allow that foreshortening. Imagine a rigid stent in a wavy artery.
Yeah.
Right.
I mean, that's why we've seen these stents fracture. I mean, just a normal bare metal stent, we've all seen those fractures, and they don't do too well.
And DCBs are great if you get an ideal result. All right.
Exactly.
Exactly.
So let's go into that. I mean, the leave no, you mentioned it earlier, leave no metal behind. That was a big phrase that, got into the whole adjunctive techniques such as DEB and even newer lithotripsy. So what are some adjunctive techniques that don't involve metal? Do you do atherectomy a lot?
Yeah. But first, let me sort of make a comment about the leave no metal behind.
Yeah.
I always use as reference, one of my well-known colleagues would say when doing tibial work, I never finish a case until I feel a pulse. Now, of course, you and I both know that, that's not always possible. But, as we discuss it, it makes a point. That should be your goal, right?
Yeah.
Ideally, you should never leave a case you have a pulse. Right. And the same thing I think applies here, by, sort of having that expression, leave no metal behind, we who speak about those things, we're trying to make the point that that's a goal, right? Ideally, if you could get a perfect result without having to put a scaffold, particularly a slided nitinol tube provocative scaffold, that was a reasonable goal. But it was never intended to be the be all and end all.
Yeah, like a rule, basically.
Right. And, obviously it turns out that the majority of cases, you can't do that. But we still do everything we can to try to optimize our results before we put a scaffold. So, we will certainly go in. We use a lot of IVUS, first of all, to confirm that we're intraluminal or to see if we're subintimal. If you're subintimal, you're going to need a scaffold.
Yeah.
And you're not going to change that, recanalization channel just to now a balloon scaffold.
It's funny. I mean, it's funny you say that because I've seen, some people when they do a whole subintimal recanalization of a long segment fempop, and, sometimes they think, oh, can I just do drug-coated balloon after that? But you need a scaffold. I mean, that's not going to stay open,
Right.
Exactly.
Yeah. It's a shame this is not a visual presentation on the podcast because I I just put together some cases just from last week.
Yeah.
And, we're doing now in the OBL, somewhere between 7 and 10 PAD cases a week. And there were these 2 cases back to back. One was a long subintimal SFA recanalization, but spontaneous reentry. And, only by IVUS did we see a subintimal. We went ahead and actually there's a lot of calcium, hard to cross things out. And it was a lot of medial calcium. But we went ahead and did some very gentle laser atherectomy to make some room, even though we were subintimal.
Sure. And
then we did our balloon. And you can see after that with IVUS, of course, it's essentially still 70% stenotic.
Yeah.
Although the angio looked great. The next case was a long SFA CTO intraluminal recanalization. I think it's going to be much different. But in fact, because of the burden of luminal plaque and luminal calcium in these cases, the recoil was just as bad.
Yeah.
So even though the angio looked amazing, the IVUS, there was a large amount of restenosis, a little more spotty, not the entire length, but still requiring long segment scaffolds.
Yeah. And again, those are the lesions. If you leave those behind and you don't, they're going to take all that work you just did down, a lot of times.
And IVUS is so important to really understanding what we're doing. But I didn't answer your question. So, we do the best we can. We, determine it for intraluminal. We do believe in atherectomy, and we choose our atherectomy based on plaque morphology. So there's no single atherectomy device that we use. And, obviously it's a whole algorithm. We talk about why we choose what we choose. We actually believe increasingly in thrombectomy, so very often, I'm sure you've seen these cases, been popularized CTOs, and you go forward with some sort of aspiration device, either incorporated in atherectomy or a standalone thrombectomy. And now you create a lumen, to get rid of potential debris. After that, we vessel size appropriately with IVUS. We'll go ahead and do POBA, unless it's a very short lesion. And if it looks great with POBA, now we'll go with DCP.
Yeah.
If we know we don't have flow limiting dissections and things like that. Otherwise, we're looking at using some sort of biomimetic, stent platform for the most cases.
Yeah. Yeah. Perfect. That's great. I was just going to ask you your approach algorithm, but that sounds great. So say you need to put a scaffold. I mean, what the kind of metal scaffolds we have, the least metal, that's going on is the TAC device, right? Which has been great and really kind of just a cute, like tiny dissection flap. I've seen TACs being used in a very high recoil situation, and that is obviously not the proper place to put a TAC, correct?
Right. I think you're right. Yeah. I'm actually pretty hot on the TACs, but early on, like all technology, when we got it, we were trying to use it everywhere. Yeah. And, as we've, grown on our learning curve, now we realize it really is for focal dissections, and it could be inflow and outflow. It's also very good in, certain, sort of areas where you may be concerned about a stent, as you get into the lower popliteal, of course, various ostia and things like that you may not want to compromise. But and like stents, we're not uncomfortable opening 2 sets of TACs if need be, but it really is for focal, discrete dissection repair at the inflow or outflow, or as a single solution. And it's really great, particularly when combined with DCB. I'm sure you've seen some of the, October 3 data, and they're running 95% primary patency out of the year. So,
yeah, when used right, it's great. I personally have used it wrong, where I thought maybe it was not that elastic of a lesion or a dissection, and then it's I was like, oh, that's but you live and learn, and then if you use it right, it looks really good and works really well. Do you typically again use IVUS and determine for TACs?
Yeah, we're using IVUS in almost every case.
Good.
It's amazing how much we've learned, now that we use IVUS, and it's part of our optimized angioplasty routine.
There's so much. We've talked about it endless times. How much more information IVUS gives, and so you always get more information, and just need to learn how to interpret that, right?
Yeah, that's true, because it affects your endpoint. Right? Often you think you're done and you're happy and you're ready to move on.
Yeah, I didn't want to see that. All right, so more metal heavy scaffolds. Really, the 2 stents that come to mind in the distal fem pop are Supera, which has been around for quite a while, and a newly developed stent that's available now, which is BioMimics. Other than those 2, I know Viabonds used to be used. I personally don't use Viabonds that much in the infrainguinal segment for just, your typical CLI patients, but are you using Stent Grafts?
Yeah, Again, like you, we don't use them as much as we used to, but then we'll use them. Sometimes you get patients who you want to avoid a lytic, aspiration doesn't work, you need a reline strategy, something like that. Sometimes you get patients or other things that all failed. So try something different, but certainly not our go-to. I think you're right. We're pretty much 50% now, probably Supera and BioMimics. And we found that BioMimics stent to be a really, really great stent. Obviously, there's a lot of precision in deploying it. And although we like to think we're perfect with the Supera, there's definitely more challenges in it.
Totally. Well, good. So you're 50-50. The Supera, I mean, these stents, the Supera and BioMimics are different. We were talking about rigid nitinol tubes, right, in this area that just don't work. I mean, we had FDA indicated life stent and whatnot, but that I used a couple of times, and each time each fractured. I will not use those in that segment. But the Supera, we've used for a long time, and I have yet to see a fracture, but it's hard to deploy. I mean, what's the design of the Supera, and how is it delivered for our listeners?
Yeah, so the design of the Supera, as you know, it's a woven, nitinol stent, so it's sort of like a spring in a Bic pen, right? And obviously, since nitinol, it's got thermal memory. The big thing with Superas is you need to be extraordinarily aggressive about vessel prep. I remember seeing Andre Schmidt spend 45 minutes on doing focal force angioplasty to kind of fully dilate one area, before he went ahead and deployed a Supera. And, we try to be almost as rigorous as that. I mean, you really have to go down there. You have to do some plaque modification. You can do that however you want. We tend to use atherectomy. And then you have to go ahead and, dilate. And they say 1-to-1, but often we're 1.1 or 1 millimeter bigger, which is interesting because when we use these in the popliteal, we find we're using balloons that we would not normally have used.
Okay.
Because we worry we'd be causing injury.
I know exactly. Yeah. You almost think like, okay, if I do cause an injury, it's okay. I'm already going to stent, right? So you already have that plan. So it's okay.
Right. You're already committed. You're down that road. So and you have to make sure you don't have any residual waste on the balloon as best as you can. It's very important. And I think, there may be a role here for shock waves too. So you get these very, very dense calcified.
Totally.
So you get now, as you said, a more elastic vessel. And once you get that vessel prep, well, then the deployment's much better. But, it's a combination of forward force on your front hand. And then, of course, the thumb motion on your backhand. And as you get a sheet, you want to compress rather than elongate.
Yep.
And they have very nice pictures, where you can sort of see the stent margins lining up like little soldiers. That's an optimal deployment. And, it's a lot of work. We really like them, but it's definitely more work. On the other hand, it's very gratifying when you get a great result. Yeah. And, I know from the Viva OPC in the popliteal segment, they're above 85% primary patency at 3 years.
At 3 years. Good. And then, so vessel prep is so important. Sizing is important. I mean, that's where IVUS, you really can't just measure on angio and say, okay, this is the appropriate size for a Supera. Sizing is when, that deployment takes a while, but it is very gratifying when you have that. Now you're like, okay, all right, this is going to do well. So what makes, so this BioMimics stent, we actually just got in our lab a couple months ago. Pretty interesting design. What makes the design different than other stents?
Yeah, so the BioMimics stent has this sort of center line, along its configuration, and therefore, and there are great videos of this, as the biomechanics change in the distal SFA pop region, it's made to accommodate that. It kind of rotates and curves and foreshortens, to really match what's happening physiologically in the individual. And as a result, you kind of maintain, say, swirling flow, but I kind of think of laminar or parabolic flow. And, we all know that that's key. If you get turbulent flow, that's when you get, PMN rolling and all these other things, which lead to that phenotypic change of the smooth muscle cells and intimal hypoplasia. But if you can maintain this swirling laminar flow or parabolic flow pattern, that in and of itself is anti-proliferative. It leads to the formation of a complement endothelium. So the structure itself promotes good healing and prevents intimal hypoplasia.
So you mentioned like this center line or a helical design. If you put the stent, ex vivo deployed on a table, it almost looks like a sine wave, right? That's kind of what it looks like. And also it doesn't lay flat. It's a little bit, there's twists in it. Other than the laminar flow, is that supposed to, mimic the same sort of crests and troughs of the popliteal artery or whatnot when it compresses? Or that's not really the idea? The idea is that it can just shape to what it's needed.
Yeah, that's a good question. I'm not sure if that was necessarily the idea in creating it. The idea was to create a helical flow pattern. But that being said, when you look at models of, cadaver models of SFA pop segments in flexion, they assume the exact same configuration as this, kind of helical structure of the BioMimics stent. So maybe it was chance, or maybe that is good engineering, but, what happens is when these stents are in and you compare them native arteries in the flex position, they assume the exact same, anatomic configuration. So they're very well suited for that.
And what about in a non-flex position? Is it causing any stress to the artery when it's supposedly straight, or not really?
Yeah, no, not really. To tell you the truth, we're not really straight that often.
Yeah.
We're both sitting here.
Right. Yeah, that's true.
Bent. Yeah. So
we're always walking, moving or something, or you're right.
Right, exactly. So, it does not seem to. If, you've seen their Mimics 3D data now, which is out 3 years, and they're over 75% primary patency with a lesion length, which is longer than most studies. As a matter of fact, their primary patency rate at 3 years is essentially the same as Alluvia, and their lesion length is slightly longer. It's about 12.5 centimeters. Their freedom from clinically driven TLR is over 80%. So, the idea of using drug delivery technology, to get better patency is only true before you had these, third or fourth generation stents, which have comparable patency.
Yeah, that's right. That's right. What about now? We talked about the delivery of Supera is a little hard. What's the delivery system to the BioMimics? What do you do?
Pin and pull.
Exactly.
Yeah.
I love it.
Yeah.
Not even a wheel or anything, just standard pin and pull, which is
right.
Great, right?
Yeah. You still want to get good vessel prep. And, I said I'm 50-50 because in our population, we still get patients who have dense calcification. Those dense calcification, circumferential calcification, they're still leaning more towards Supera. But again, if you look at the BioMimics data, I think 40 or 50% of those patients, or about 40%, had moderate calcification. So you can use it in calcified arteries, quite well with the vessel prep.
Yeah, vessel. And the sizing, Supera, you want to size 1-to-1. Is the BioMimics stent more like you can oversize by 1 millimeter, or do you still go 1-to-1?
No, the recommendation is you go 1 millimeter over. So, obviously, I'm not putting 7 millimeter stents in a vessel I'm not dilated to 6. That's probably because I'm over dilating the vessel. Yeah. The vessel is a 5. I'm doing a lot of vessel prep, and then I'm putting a 6 millimeter stent in.
Got it. And, I've never seen a Supera fracture in that thing does not want to fracture. I'm sure there has been, but I haven't seen it. Is the BioMimics the same? Is there fracture reported in that segment or no?
Yeah, essentially no fractures with the BioMimics, and
that's great.
Very, very low rate with the Supera. I actually just saw one 2 weeks ago, patient who had a Supera in for 8 years or so, something like that. And there was actually fracture in 2 spots. Hadn't seen that in a very long time.
Ooh, he must have been doing lots of jumping jacks or something. That's tough.
It's actually, as a truck driver, I asked him, I said, are you crouching down a lot, or what are you doing? Good job, this happened.
So one of my questions is going to be, what lesions do you use Supera for and BioMimics? So you touched on it. You said, potentially the heavy calcium that are elastic, you would maybe do Supera to get that radial strength. Is there any other lesions that you would lean towards either stent or trying to go more towards one stent or the other?
Yeah, so absolutely. So certainly, again, although we're perfect at every time, as we get lesions that are proximal SFA and ostium, or lesions where I need, to be very precise landing before a big collateral, which I may not want to compromise, I'm going to go ahead, almost always use the BioMimics stent. It's the precision of placing that. There's very, very little foreshortening, and it's reliable. They're also interesting, and this is not talked about as much, cases where I just cannot get, adequate vessel prep. I just can't, I just can't. Dense calcium, I've done everything, it happens. In those cases, once you elongate the Supera, you definitely lose, patency, and you can't now go in and
you can't plastic it. Yeah, no, you're done.
You're done, right? Yeah, that's it. Your hands are tied. So in those cases, we will go ahead and also, even though it's dense calcium, lean towards using a BioMimics stent. Even if we could then go ahead and sort of reline to a crack and pave, or I guess pave and crack strategy in that case.
Describe that more, the Craven pack. You actually stent and then crack it after?
Yeah, exactly. I mean, we're talking about patients who are my normal balloons, which go to 20 atmospheres, have not really done it. So there's cases that are coming back. It's just a really flow limiting lesion. And I'm going to have to take out a Conquest 40 type of thing,
Yeah.
It doesn't happen too often, but, you can do that all you want inside a elongated supera, and you're not going to change the result.
Exactly.
You get a perforation, but you won't get change the result. Yeah.
True.
So you can change the configuration with the BioMimics stent. And that's, doesn't warrant too much discussion because it's a less common scenario. But I think what I want to say is we don't necessarily avoid the BioMimics stent in circumferential dense calcium.
Okay.
And as we get good vessel prep, we may want to use it more. One, in the lab, it's very cost effective for us. The lengths are good. The reliability and deployment is very good. So that's pretty good if you think about it. I mean,
there's a lot of good pluses. I mean, in our experience so far, we've been pretty happy. I mean, essentially it's new experience. So I'm looking forward to see how my patients do, but it's like, whoa, I was able to stent that 20 centimeter segment like that, whereas I'd still be stenting with the interwoven stent, because it takes so long to deploy.
Right, exactly.
Now, what about distal? Let's go distal to the pop, trifurcation disease. Have you been using this? I know it's off label, but have you been, since it's 5 millimeters and you can oversize, have you been using it in the TPT or doing sort of, crazy revas of kissing coronary DESs barreling into the stent? Have you had experience doing that type of work with this stent yet?
Were you watching our ICID live cases?
No, I was not. Was that what you did?
Oh, yeah. It sounds like something like that.
I love a kissing coronary and barrel into a stent. That's
right. Crazy recanalization, cullotting stents one into another, coming across native arteries that have been failed bypasses and things like that.
Love it. Love it. Those make me so happy when I get to do that.
Yes. Right.
But yeah, how's your experience with that with the BioMimics?
Yeah, so we've used the BioMimics down into the P3 segment and a little bit of the tibioperineal trunk.
Okay.
Although not that much,
Okay.
I mean,
so
in that segment.
AT.
Right. We've, done some tacks, and of course we use some coronary DES if the anatomy allows it. We are doing, again, a lot of IVUS, a lot of atherectomy, a lot of angioplasty. But, if we're going to do kind of some sort of kissing technology there or colliding, usually it's going to be off-label use of coronary.
Got it. And, back in the day, I don't do it as much, but when drug-coated balloons were pretty popular, sometimes we would do a stent and we would actually combine like a bare stent, and we would maybe put some drug on the distal ends with plasty, kind of like a combo approach. Have you done that at all? Or do you believe in that? I haven't done it in a while now, especially when DEBs kind of went down a little bit, but the one before, I definitely had tried that.
Yeah. Well, that's the debate SFA approach. Dr. Ciabalis wrote that paper, and, the intended take home was that bare metal stent plus DCB is the same as DES.
Mm-hmm.
And they showed pretty good patency, although they're about 75% at 2 years. I think it was very close. So that's a reasonably good strategy. We've not been using that, and it's interesting. I mean, obviously, like everybody else, after the Jaha article, we kind of pulled a little bit away from DCB, but I think the vast, majority of data shows that DCBs are safe in terms of vital statistics. So we've now kind of incorporated them again. We'll use DCBs very comfortably, even in the outpatient lab for relatively short, to intermediate length lesions. We can get away with sort of one DCB. We have a perfect result after vessel prep and POBA without dissection or flow limitation. However, we're also very comfortable because of the excellent results of the BioMimics stent and Supera platform, to sort of wait and see, do surveillance, and if need be, come back and use DCB as a secondary technology.
Got it. Not the other way around. Do DCB first, then come back, and if it doesn't work, then stent, which is kind of where the leave no metal behind stent kind of concept, right?
Right. I mean, as a primary approach, we'll get those lesions where DCB is perfect, right?
Yeah.
It just the vessel on angio and IVUS is completely normal after you've done your POBA DCB, and that's great. I love that.
Those are the ones that are durable with the leave no metal. Absolutely.
Right. Exactly.
So future tech, people have talked about absorbable scaffolds. Are those ever, in your experience, I know you have your hands in a lot of things. Are you feel like that's going to be a viable option in the future, or that's kind of a vanishing goal?
Yeah, and well, obviously, below the knee, we participate in Sabal, we participate in Life BTK, and we participate in Stand, which is micromedical, which is sort of the supera of the tibial arteries, right? Again, it's sort of a woven nitinol stent. So, yeah, I mean, look, those technologies, the tibial circulation, as you know, we don't have other great options, particularly as you get in the mid and distal tibial arteries. We've used tacks in that segment because you can't use balloon expandable stents, which is subject to plastic deformation and crush. But we definitely could use some other options. I do think there's probably going to be a role for bioabsorbable platforms or other stents in general below the knee. Above the knee, I don't know. I mean, your value proposition now would have to exceed what we're seeing now with these third and fourth generation biomimetic stents. That's going to be hard to do.
That's hard.
And
I mean, we're at 85%, 75 to 85% in 3 years, right?
Yeah, exactly. So, I mean, the likelihood that we're going to gain much utilizing potentially very expensive technologies is not certain at all.
Yeah. Anything else you want to kind of discuss about this distal fempop segment? Anything, we didn't cover just now? We covered a lot, but something, people, operators, maybe early operators or people who are getting more experience about this segment, what to do. Obviously, IVUS is huge in your practice and should be in everyone doing, high level PAD. Any tips and tricks that you want to tell our listeners?
Yeah, particularly for early operators, you should probably get comfortable doing some of these sort of flexion angiograms. We don't routinely do that unless we're treating popliteal artery aneurysms. It's funny, every time you treat a popliteal artery aneurysm, you do this to see where to land your grafts and make sure you don't have any kinking. But we don't do it for an atherosclerotic case.
Yeah, that's great. Yeah, a great point.
Right. Yeah, I mean, so it's not a bad idea until you get comfortable with these things and understand your patient and where that compression is occurring. After you put that stent, go ahead, do that flexion angiogram, and you might learn something really valuable in terms of, whether you have enough metal, you need more metal, you need less metal, and how you can optimize your results. So
that's great. Actually, I'm going to incorporate that tip in my own practice. You're right. I don't do that many flexion views unless I have to, but doing it more routinely, I'll probably learn a lot more.
Right. Right now you do it when you have a talk coming up. So you take
exactly. I'm going to do it tomorrow. John, it's been great having you on. I mean, this is definitely, it's exciting to have new technology. I mean, with our, non-metal options, atherectomy, lithotripsy, DEB, and having new stents available to us like BioMimics and with Supera. I mean, it's nice to have a lot of options to treat these patients that, otherwise may lose their foot or leg. So thanks a lot. Thanks for being on our show. I mean, we really enjoy all the stuff that you're doing and changing the field of PAD. So keep doing what you're doing. We love it.
No, I appreciate it. It's very kind. And, what you're doing is also spectacular. I mean, you really have a very popular platform there. I admire everything you've done. And I can't thank you enough for allowing me to talk to you this morning.
No, thanks. It's all because of our great guests. So thank you so much. And thanks to everyone. Thanks to our sound engineer, Caleb, today, and everyone else at BackTable. Thanks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabeen Dhand,
Michael Barraza,
Brian Hartley.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
And newsletter by Lauren Fang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.